Well, welcome everybody. We're very pleased to have you join us in this Columbia SIPA Earth Institute Mailman School webinar on COVID policymaking in the throes of a global crisis. And I'm delighted to welcome our speaker today, Jeffrey Shaman. I'll introduce him in just a minute, but I also wanted to let everyone know that we also have our co-host, Jeffrey Sachs, university professor at Columbia and a professor in SIPA in the Mailman School, and former director of the Earth Institute, who now heads up the Center for Sustainable Development. And we're joined by Yanis Ben Amour, who's an adjunct professor in SIPA and executive director of the Center for Sustainable Development. Andrew Wilson, as always, is in the command center. Thank you, Andrew. And again, I'm delighted to welcome Jeffrey Shaman, who's a professor of environmental health sciences in the Mailman School of Public Health, a colleague of ours in the Earth Institute. And he also is director of the Climate and Health Program at Mailman. He has a really unusual combination background of climate science, and his first degree was in biology, and he combines these for the work he does in infectious disease modeling. And I knew his work on influenza, and he now has become one of the world's leading experts on the transmission of COVID-19. And so we're delighted to have him. When I drew up a schedule of our webinar, looking ahead at the when the election was going to be held, I did have a worry about how I could put someone in this position of speaking the day after an election. And Jeff was very, very kind to agree to speak today. And I think at that time we weren't quite sure how things were going to turn out. Well, we're still not quite sure how things are going to turn out, but we've got this major crisis to deal with. And Jeff has his pulse on the most critical aspects of the transmission of this disease. So we'll, as usual, ask Jeff to speak for about 20 minutes, and then we'll go to questions. Jeff, thanks so much for joining us.
My pleasure, my pleasure. I'm going to share my screen with some slides, and I'll speak for about 20 minutes. I'm going to talk a little bit about the transmission dynamics of this virus, why it was really fated to be a pandemic, and what it has meant for our ability to potentially control it and think about it using mathematical modeling. So Scott, can you see these slides?
Yes, that's great.
Okay, great. All right, so I'm going to just, I always give the funders in any talk, even something like this, because this is really research driven, and if I don't put it up front, I don't remember to show it. Similarly, I like to put my collaborators up front because I sometimes will forget to go to that slide if I tack it on at the end. There are a lot of people who've contributed to various facets of this work. I'd like to particularly point out Dr. Sen Pei, who's an associate research scientist in the Environmental Health Sciences department in my group at Mailman, and a mathematical modeler who's been really integral to a lot of this research. So I'm actually going to take a step back and tell you how my thinking was informed by a project that we previously had going on. That was a field project in Manhattan. It was called the Virome of Manhattan. It was funded by the Department of Defense. And its mission was to try to better understand the circulation and transmission dynamics of common respiratory pathogens that we're contending with all the time, very often many of them in the winter time. This is something pre-pandemic that we worked on. And one of the aims of it was to try to figure out just how much asymptomatic and undocumented infections there are by these viruses and what allows them to get around. And the reason for this is that the way our systems are typically set up for monitoring respiratory viral infections is that we have a passive surveillance system. By passive, I mean that we wait for people who are sick enough that they want clinical attention to actually seek that medical care. And it's only those individuals who will actually be documented. They're documented as either syndromically by given the label influenza-like illness, and that's if they present to a doctor with a fever of 100 degrees Fahrenheit or greater and a cough or sore throat. You'll get this ILI or influenza-like illness label. And those individuals then may also be swabbed and tested for individual respiratory pathogens, and we can see what the positivity rates are for those. Within the US, there's a network of several thousand clinics that actually report to public health agencies at county, municipal, and state levels, and these are aggregated up to the CDC, and that's where we get indicators of how much respiratory viral activity there is, in particular influenza-like illness, influenza positivity rates, respiratory syncytial virus positivity rates, etc. Now, because it's a passive system, nobody's going out in the community and actually sampling those individuals who are not seeking clinical care. So we have no way of really knowing how much is out there broadly and what's allowing these viruses to persist. So as part of this Virome project, one of the arms was to set up a cohort where we could actually look at this through an active sampling program. In this cohort, we ultimately enrolled over 200 individuals over a 19-month period from October 2016 to April 2018. So it spans 2 cold and flu seasons, the wintertime in New York. We recruited people from daycares. These are both toddlers and their parents, from a high school, both students and teachers, nurses and doctors from a couple of emergency departments, as well as people who work at the Columbia University Medical Center. What we asked them to do was to provide an initial survey where they told us about their symptoms and syndromes and demographics, their baseline conditions, as it were. And then on a daily basis, we requested that they give us a rundown of their respiratory symptoms. So on a Likert scale, none, mild, moderate, or severe, they would tell us what they were experiencing on that scale for things such as runny nose, sneezing, cough, sore throat, chills, etc. There are 9 of these symptoms. They can enter it very easily over their phone directly into an electronic database. It was a very high compliance rate for doing it. It took all of 30 seconds to accomplish. And in addition to giving us those symptoms, they also told us on a daily basis if they had stayed home from work or school because of their symptoms, if they had taken medication to deal with those symptoms, or if they had gone to see a doctor because of their symptoms. Then, in addition, on a weekly basis, regardless of how they felt, we would swab them. We would take a nasopharyngeal swab, take it back to the lab, and then test it for 18 common respiratory viruses. This included influenza A, H3N2, A, H1N1, RSV-A, RSV-B, different types of parainfluenza. In this table, what you're seeing is them all grouped together into the 7 larger groups they are, including coronavirus, which is the endemic coronavirus, is not SARS-CoV-2, the causative agent of COVID-19, because it's pre that time. And what you can see are the number of episodes that we documented amongst individuals. We could define an episode as a group of 1 or more weeks in which that individual was positive for the same virus, allowing for a 1-week gap to account for false negatives or temporary low shedding. And you can see we had documented 32 infection episodes for flu, 30 for parainfluenza, 275 for human rhinovirus, and 137 for the endemic coronaviruses. The next column, MA, indicates medically attended. And that indicates whether or not the individual went to see a doctor during the time span when they had this infectious episode by this virus. And you can see it's much smaller. The next column shows you the probability of seeking medical attention given infection with that virus. And it's simply the MA column divided by the episode column. And what you can see is that the fraction of infection episodes that induce an individual to actually go seek clinical care is small. It maximizes as less than a quarter for influenza, and it's as low as 4% or 1 in 25 for the endemic coronaviruses, which are fairly mild. So what is this showing us? It's showing us that the vast majority of infections are never documented. They're not known. And what does this mean? It means that what happens when a person typically gets one of these viruses is what happens when you or I do it. When we get it, what do we do when we get a little sore throat? What do we do when we have a little bit of chills in the wintertime? And the answer is nothing. We still go to work. We still go to school. We still go shopping. We still get on public transportation. If we have a business trip, we'll still get on an airplane. If we have a vacation, we'll still get on an airplane. And what are we doing in this process? Well, we're taking the virus out and about in the community. We're bringing it around. We're sharing it. We're contagious. We're shedding the virus and we're moving it around. And it is this property that allows these viruses to persist in our society. That is why they're so ubiquitous and why they're present. And the interesting thing is that this documented, undocumented line is the natural dividing line to look at. And what we found as well, and is not shown by this table, is that looking at symptomatic versus asymptomatic is a much more squirrely proposition. And the reason for this is that we had individuals who reported symptoms every single day, no matter what they had. Maybe they had fibromyalgia, maybe they had chronic rhinitis, maybe they were just a hypochondriac. We're not quite certain, but they always reported symptoms. So they never had an asymptomatic baseline to work from. Then we had other individuals who never reported symptoms, no matter what virus they got. So because it's self-reported, this idea of trying to figure out symptomatic versus asymptomatic is perhaps not the most logical dividing line. But whether you see a doctor, whether you actually can be confirmed as having a specific pathogen is very important. All right, so what does this have to do with COVID-19? Well, in January, when we really got word of what was going on in China, and we saw what was happening in Wuhan and how quickly the virus spread from the epicenter in Wuhan throughout China, then hopped on airplanes and went to Thailand and then Japan and South Korea and the US. When we saw this, we immediately said to ourselves, because of this Viron project, this is behaving like a common respiratory virus. This is acting as if there are a lot of undocumented infections, and it's spreading very rapidly because of this. So what we did, which is something that we do in my group a lot, is we built a model to try to understand this and see if that was indeed the case. What we built is something called a metapopulation model. This is a mathematical representation of the transmission of this virus, SARS-CoV-2, in 375 cities. And these cities are linked by travel between the cities. And the way we got that was using 10-cent location-based service travel records that are derived from cell phone records. Tencent has penetration in the Chinese market that's enormous through apps such as QQ and WeChat, which are very popular. And it allowed us to get an estimate of the movement of people in the run-up to the Chunyan Spring Festival amongst those 375 cities. We built the model as it's shown on the left, and I'll tell you a couple key points on the next slide. But what we do with these models is we couple them with Bayesian inference or data assimilation methods. And these allow us to entrain or assimilate observations of confirmed cases on a daily basis from all 375 cities that we're simulating in China. Now, we did this simulation with this inference procedure for a very limited window, 14-day period from January 10th to January 23rd. And the reason we did this is that prior to January 10th, there wasn't enough signal. There weren't enough cases to really work from to make it worthwhile actually doing the assimilation at that point. And we stopped at January 23rd because that is when they imposed the lockdown in China and restricted all travel in and out of the city. And that quickly spread in a matter of days to much of the rest of China. So China went on a lockdown. So the period from January 10th to 23rd represents the period of time when this virus was transmitting as it would in its natural state, if you will, within Chinese society. Now, within the model, we're actually separately representing documented and undocumented infections. And the model has separate contagiousnesses for these undocumented and documented infections. We are going to use the inference that we've coupled this with the observations and the travel data to try to estimate the parameters in the model that represent the critical epidemiological characteristics of this pathogen as it moved within Chinese society during this 14-day period. Now, prior to actually doing this, we have to know whether that inference will work. This is a high-dimensional nonlinear system at this point, and we have to know whether or not we have enough observations to constrain and estimate the parameters. We have to know if they're identifiable. So the way we do this is we take the stochastic underlying model by itself without the observations or inference, and we run a simulation with it using prescribed parameters. Now it's stochastic and will produce an outbreak that will be some truth that's there. And we then take that outbreak and we feed it into the full model inference system and see if the model then can estimate the parameters that were used to actually create the original free simulation outbreak. And we do this over and over and over again with different combinations of parameters, and we see if it's continuously and consistently identifiable for all 6 parameters. And we also try to break it down. We see when it falls apart by using a reduced dimension system, reducing the number of cities, et cetera. But ultimately, what we're trying to establish here for ourselves, and obviously for reviewers ultimately, is that we can actually identify the parameters in the system reliably. What you're seeing on the left is one instance of it. We have 6 parameters in this model. beta, which is the contact or transmission rate from documented infections, mu, which is a multiplier saying the relative transmissibility from undocumented infections, theta, which adjusts the travel rate, z, which is the latency period, alpha, which is the ascertainment or reporting rate, what fraction of infections are confirmed cases, and d, which is the infection period. So the red line showed the truths, which is what we imposed and then ran a stochastic simulation for. And the distributions in blue show you the estimates that we get, our posterior credible interval, as we try to estimate those parameters in this instance. And you can see that we're able to capture all of them within the 95% credible bounds. And this was consistently so. So we convinced ourselves that we're able to actually make this estimation. And then we applied it to the actual data. When we applied it to the actual data, I want you to focus on two things. One is the reporting rate. The reporting rate alpha is estimated to be 0.14. That means that we're estimating that 14% of infections are documented. In other words, 86% are undocumented. Secondly, the relative transmission rate, mu, is 0.55. That means that per person, excuse me, undocumented infections are on average half as contagious as documented infections. We are also able to get an aggregate metaparameter, the reproductive number, out of this, and it was 2.38, which was aligned to other estimates for China at that time. So, question is this a good fit? Can we validate this further? And the answer is yes. We can take those parameters, run stochastic free simulations, and see if they produce outbreaks that are consistent with that which was observed. And what you're seeing here is that validation. The box and whisker plots are 100 simulations with this stochastic model using the estimated parameters. And the red X's are the actual observations, national daily cases in the upper left. The middle B top is Wuhan cases. Hubei province is the lower left and C. And on the bottom right, all the way over on the larger plot, is the number of cities with cumulative incidence of 10 or more cases on each day of the simulation. So we're able to actually capture and represent what happened. Now, the next question we set ourselves is, all right, well, how important are those undocumented infections, the 86% who are half as contagious roughly? Well, we can actually do a counterfactual simulation here to actually see what they constitute in terms of the transmission dynamics. We do that by setting mu equal to 0. The fit that I showed you before in blue is now in red here. But when we set mu to 0, you can see that the number of confirmed cases, the reported cases without transmission from the unreported or undocumented infections, is greatly attenuated. As a matter of fact, about 80% of confirmed cases are lost if you don't have this spread from the undocumented, which means that the undocumented infections are responsible for the lion's share of infections. They are the ones setting up the transmission chains. And we also saw within this model, and I haven't shown it here, evidence of considerable pre-symptomatic shedding and contagiousness. In other words, about 2.5 days prior to symptom onset, we estimated that there was in fact contagiousness for the average individual who was going to become a confirmed case. So not only do we have these undocumented infections sharing the virus, we also have pre-symptomatic contagiousness amongst the people who are ultimately going to be confirmed cases. And this indeed has also been since confirmed. All right, so what does this all mean? Where does this put this virus? Well, what it meant to us when we did this at the end of January was that this virus was going to become a pandemic, and that there really wasn't going to be a stopping of it without radical overhauling of how we interact with one another. And the reason why is it has a combination of characteristics that make it particularly dangerous. One, it's emergent novel respiratory virus to which the world has almost no pre-existing immunity. So we're all susceptible to it. Number two, the majority of infections are undocumented. And these people are contagious, and they're doing the lion's share of the transmission. And this allows this virus to spread very quickly within communities and between communities. And three, even though the majority of people are having undocumented infections, there is still this fat tail of people who are having severe complications to the disease. And because so many people can be infected because of the rapid spread, and because everybody's essentially naive and susceptible to it, a lot of people are going to wind up being hospitalized, and there's going to be a lot of mortality. Now, if we look at the other 6 coronaviruses which we know of that have infected humans, this virus, SARS-CoV-2, lies between the 2 extremes they represent. On one extreme, we have SARS-1 and MERS, the Middle Eastern Respiratory Syndrome. SARS-1 had almost no subclinical infections. In other words, there were really no undocumented infections. Everybody who had it was identified, essentially, because everybody had a clinical manifestation that required care. Furthermore, there wasn't any pre-symptomatic shedding. MERS had some milder asymptomatic, not a lot, but also MERS had the benefit for us that it wasn't as transmissible. It's not as aggressive moving from person to person, so it's not as efficient getting around. Then on the other side, we have those seasonal coronaviruses. In the Virome study, we had about 135 infection events. Most of them are mild. Most people don't seek clinical attention. They have these funny alphanumeric names like OC43 and NL63. These guys are on the other side. They are the persistent mild infections, again, that get around all the time because most of them are undocumented and people are sharing them all the time unwittingly. Unfortunately, SARS-CoV-2 lies in between. It produces severe outcomes and it gets around like a seasonal coronavirus. All right, I'm going to wrap up pretty soon because I've gone on my 20 minutes, I believe. But I'll just say that, we've taken the same system. We've applied it to the US at county scale. We use travel data from the Census Bureau initially, and since then we've been using mobility data from phones to know rates of movement between counties. And we can use it to make estimates of a similar sort for the United States. Here was our first estimate that we did through March 13th. Here, instead of 14%, we're getting an 8% reporting rate. So instead of 1 in 7, it's about 1 in 12. And that lower rate is consistent with the fact that we weren't testing as much and we didn't have the testing capacity that China had at the time. In addition, we've added additional features into the model. We allow beta and alpha to vary by location, by county. We assimilate both cases and deaths now. And in doing so, we're able to make an inference and a fitting to understand how the reproductive number has changed over time as more and more measures have been imposed. Now, typically we think of the reproductive number as sort of this innate quality of a virus that allows it to get around. But if we're wearing masks all of a sudden, we're socially distancing, we're closing schools, we are disrupting those opportunities for transmission, and we are lowering that reproductive number. So what we did in this exercise was to estimate how much that number has been lowered. We fit the model to cases and deaths in the United States on a county by county basis through the beginning of May. And this shows you the fit at the national level for both cases and deaths, and then for the New York metro area in the middle row. And then from that, we could also derive these estimates of the reproductive number shown in the lower left. And we aggregate it and show it for 6 metropolitan areas here. And you can see how they have somewhat different trajectories, but they're all declining in March to the middle of April. Some of them, like Chicago, are hovering at or above 1, which allowed for a continuing outbreak there. Others are getting well below 1, which is the critical line, at which point you're going to see a decline in infections there. We then asked ourselves, well, what would happen if each of these cities had done their exact trajectory, each county in the US, but they'd just done it 1 week earlier or 2 weeks earlier? In other words, we're not saying that everybody gets their act together, but San Francisco, which acted very early with the shelter-in-place order, suppose they had done it a week earlier even. And suppose other places which were much later in their response did what they did a week earlier and followed the same trajectory. What would the change have been? And we did this and we ran some counterfactual simulations to see what the changes are. Now, early in an outbreak, early in any outbreak, and that doesn't mean early in the pandemic, we're in the midst of another outbreak right now, you have exponential growth. And if you act on it earlier, it acts to your benefit. And what we saw was basically that if we'd acted 1 week earlier, there would have been a 50% reduction in deaths through the beginning of May. And if we'd acted 2 weeks earlier, it would have been a 90% reduction in deaths through the beginning of May. Now, that same thing, we then said, well, that informs what we need to do. This is a study we did at the end of May, and we said, look, as everybody seems to be reopening at the time and all the states are relaxing their restrictions, we're going to confront a problem where there's going to be growth. If you don't act on it quickly, you're going to have large outbreaks. Even a 1 week delay in response will result in substantially more cases and deaths. And unfortunately, that's what manifests in the Sun Belt over the summer in July and August. And now we're seeing it again in the fall when it's even more challenging. Just to tie it up, we've done a lot of other things with these models. We've looked at optimizing interventions. So this is how you get an optimal hurricane evacuation plan that not only gets people out of where the hurricane is making landfall, but puts them in places where you're going to minimize the number of cases that are going to be fomented because of the mixing that takes place by the evacuation. We also have looked at return to work policies and what are the most effective testing strategies. And those are just a few of the examples of some of the counterfactuals that we've done. So I'll stop here so we can get into the Q&A now.
Jeff, that was brilliant. Thank you so much. And I want to say to your financial sponsors that they're getting good value for their money. And this is a great public service you're offering us. So thank you so much.
You're welcome. I'll tell them.
Yeah, tell them I said so. I want to ask you two questions. The first is on the modeling, which I know is something you care about, and not everyone cares about the modeling, but they do care that we control the disease, and one way to try to know how to do that is through the modeling. So the modeling really is quite critical. And so one comment is about the modeling, and I'm not as engaged in it as you are, obviously, but it has troubled me that these mathematical epidemiological models tend to emphasize certain things like the basic reproductive numbers being quite critical. And they leave out other things. And in particular, the whether people who are infected show symptoms, whether they remain asymptomatic. In other words, whether they're infectious before the symptoms show, or whether they remain asymptomatic while they're still able to transmit. That's really critical. And that was one of the features of the 1918-1919 influenza pandemic, was that people were healthy, didn't know they were sick. No one could tell that they were sick, and they were walking around and transmitting. So just like you were describing earlier on, and SARS was totally different. So right away, it struck me that that was a way to think about SARS-CoV-2, that you've got these two different benchmarks, and the R naughts were very similar for all three, but the whether the symptoms showed, that was really critical. And the other point to this is that we really need a kind of behavioral model, not just a mathematical model where you're kind of fixing how people act, but a behavioral model, because people behave very differently if they're sick or they're not sick. Yep. And they behave, right? And so I use these very simple game theory models where that's intrinsic to that approach. But I think that really is quite critical, and it's actually one of the things that would drive waves. So you can get a wave anyway without that. Mm-hmm. But when you add in that tendency of humans that when they see the risk falls, they take fewer precautions, which is kind of building up the momentum again for another wave, right? So there are those two things, and I don't know if there have been advancements in the modeling, but that's my first question. My second question has to do with the election, and in particular, two candidates who had totally different perspectives on what to do about this. So we've got Trump, who says, hey, this is no big deal. Obviously shows no regard for the need to wear masks. Mm-hmm. He dismisses any scientific opinion that says this is a difficulty, ignores the fact that over 200,000 Americans have died and that something could have been done to stop that. So he's kind of saying, hey, you should go about and do what all these asymptomatic people do and just do your business and don't worry about it.
Yep.
Whereas Biden, has been wearing a mask, says he would appoint Anthony Fauci as his lead advisor, whereas Trump wants to fire him. And he has suggested that there'd be mandatory mask wearing throughout the country. Mm-hmm. And I know that your work has shown that mask wearing would reduce transmission, I think about 30%, but quite significantly. And in particular, if you had mandatory mask wearing, then people who did not show symptoms, but who were infectious, would then not be transmitting as much. And this is really quite critical. I think a lot of people don't understand is that when you wear a mask, you're doing it to save other people. It's not about you, it's much more about them. And that's really kind of a way to understand those two candidates too. So one is very much about, well, ignore science, and it's all about me, 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 me. In particular, it's about one person. Mm-hmm. The rest of us are just the audience. And the other person who's about, it's all about the we and togetherness and solidarity and so on. totally different visions. And so I'm just curious, what are what are we talking about in terms of the difference for cases and deaths in the United States because of these totally two different perspectives that would be reflected in policy? I think the differences have got to be huge, but I'm sort of curious if you have any sense of that.
Let me start with the second question. I think you are dealing with obviously an unfortunate circumstance where somebody who really is not beholden to evidence and is not really concerned about anything other than his own re-election is in charge at a time where leadership really matters. And I think you could argue that usually this country can get along regardless of who's in charge in its own stumbling, bumbling fashion. And there only are a few instances where leadership really matters. And unfortunately, this pandemic is one of them. And what we've had is a complete, not just a failure, but an abdication of the responsibilities of leadership. He literally said, I'm not doing anything more in late April. He got frustrated with all the difficulties associated with it. Not that he was really doing anything but having a daily press conference where he could perform. And he said, it's the governor's responsibility to figure it out. At which point you then have 50 individuals now making their own choices about how we're going to deal with it. And they don't have the power to print money or the strategic defense stockpile or any of the resources of the federal government to make it really happen. So you have that, and you have somebody who made mask wearing a partisan issue, who tried to make school reopening a partisan issue and did push it that way, who made it part of the identity politics that we have here and allowed the idea that we have to think about individual liberties and civil liberties be a legitimate part of the discourse, which it really shouldn't be at certain instances like such as this. Part of that may reflect, and this is obviously my own opinion, the fact that this country hasn't been asked to have a collective sacrifice of any real magnitude since World War II. And nobody's around who remembers that. Nobody's around for rationing of flour and sugar and women going off to work at the time when they weren't working and the general sacrifice that people had to make for a collective aim. And we needed that now. And mask wearing is emblematic of them because, as you say, its actual primary effect is not necessarily to keep you from getting infected yourself, but prevent you from infecting others. And it's something that you can do both to protect yourself as well as protect others. It's not just like buckling your seatbelt, which is going to save your life. It's as if, if you don't buckle your seatbelt, you become a human missile who takes out other people. It really is something that if we had had the right communication, if we had had an evidence-based approach that said, look, we're learning as we go, we're going to change, we have recommendations we're going to make, and as we learn more, we're going to change it, we're going to ask you to do things for the collective good. And that also managed expectations. That was something that was crucially missing from this as well. We needed a Churchill-style leader who could manage people's expectations and rouse them to do the right thing so that we can get through it and know that it's going to be hard. I mean, the evidence was there, unfortunately, even in March, that places like Vietnam and Thailand and Taiwan and South Korea and New Zealand were more effectively dealing with this issue than the rest of the world was. And yet we didn't stop, even though people were saying it at the time, including me, and say, look at what they're doing. They're not even doing the same thing, but they have an aggressive strategy in place to first control the virus so that they can get their economies going, all right? And if you don't do that, you wind up doing neither. Your economy gets completely disrupted and you can't control the virus. And we're seeing that in most of the world. Most of the world's a failure. Europe right now is a disaster. I mean, Belgium recorded in the last couple weeks case levels that would be akin to over 500,000 cases a day in the United States. That's the rate at which they're going. France, over 250,000 cases in single days, given the size of their populations. So it's not just the US that is completely failing at this. But the question is, why aren't we learning from these other countries? Now, you can make the argument that those other countries had the experience actually of SARS-1 and MERS. That's where they were. And they were maybe a little more sensitized and attuned. And some of them did have really good plans in place that they acted on. and they acted very aggressively to control the virus. But it's a hard problem. And we had a government that just shied away from it. They don't know how to work. They don't know how to actually do things. And there's a lot of blame that can be cast around generally, but a lot of it has to be directed toward the federal levels. So when we look at what's going to happen now, and you say, well, Joe Biden has a plan for doing this, this is all well and good. My concern is, can he penetrate the news bubble on the right? I think in actuality, Trump, if he were a different person, if he were a better human being, he had such an opportunity to win by a landslide if he had done the right things with this virus, if he had really put the effort in and made it happen, because he already has his base listening to them and they'll do what he says. And if he works from reason and evidence, he will get the left to listen in droves. Maybe not everybody, but a lot of them. They'll do what's right. It's a lot harder, I think personally, for a President Biden, should that come to be, to actually speak across the wall that is Fox and Breitbart and all these other things that are there right now. And that's going to be an enormous challenge. I can't emphasize enough in my mind how important leadership and communication are for actually managing something like this. And even January 20th, it will not be too late. We will still, in all likelihood, be contending with this virus in a substantive way where it's still infecting people and killing people, that we would want that leadership in place to actually talk to the people and speak to them. Getting back to your other thing. Yes, behavior needs to come in. Very, very complicated issue to bring into dynamical models. They're nonlinear systems. They explode with error if you're not careful. You have to keep them simple if possible. But we have clear examples of how important behavior is. And you're absolutely right. I mean, our whole dichotomy of documented versus undocumented infections is to try to represent that, and to represent that people are doing things without knowing that they're actually transmitting the virus. And the recognition that there is pre-symptomatic shedding. Absolutely. And for flu, this is a big problem for it as well. In addition to the fact that 75% of the people with flu never even go to see a doctor, right? But we've seen the power that behavioral modification can actually happen. And the best example I know of is for West Africa during the Ebola outbreak that took place in 2014. In that time period, we had no idea what was going to go on. I have to tell you, that scared me more than any infectious disease has ever scared me. I was really disrupted and disturbed by what I saw there, because I really didn't know what the end game was going to be. And what I didn't know was that when this virus got into villages, all the conspiracy theories, all the distrust, all the disbelief that was existing in the population went away after a week or two when they saw how horrible this thing was. And how, I mean, it's palpably horrible, with people bleeding out of their orifices and dying in horrible ways, with this utterly cranked up case fatality rate that makes SARS-2 look like a picnic, okay? What happened was they stopped touching each other. And I have colleagues who went there and worked in Liberia and Sierra Leone, and they would come back after 3 or 6 months and they'd say, I didn't touch another human being the entire time I was there. No handshakes, no brushing, nothing. Nobody touched one another. And it stopped the disease, because this is a contact-driven disease. You have to come in contact with the fluids, the bodily fluids of somebody who's infected with it. So behavior can be enormously important, and it has already been important for this virus. This virus, if we hadn't done all the non-pharmaceutical interventions, the restrictions of mass gatherings, the closing of restaurants, the telecommuting, the shuttering of bars, the social distancing, if we hadn't done all that stuff, we would have 800,000 people dead in the US already. It would have steamrolled us already, all right? And so we're in a better position because of that, in spite of the lack of leadership, because people are concerned about it, and enough people are doing enough things that we've really reduced the transmissibility of this virus. The problem is, so much of it is dependent on not just political implementations of policies and the shuttering of restaurants, let's say, and the closing of schools and the things that you can do at a supervisory level. It's also reflective of all the microscale interactions that we don't observe. that are really hard to pick apart, which is how close are people really coming to each other? You know, how much are they actually commuting? How are the restaurants situating people at tables when they're dining there? How are people wearing the masks? What kind of masks are they? Do they have them on their chin? Do they have them over their mouth? Do they have them in their mouth and nose? What are they doing? You know, we've all seen all the combinations. You just go out in New York streets, you see all of them, right? We don't know what that maps onto in terms of opportunities for transmission of this virus. And that makes it very, very difficult. So one of the things that I personally get in a huff is we've had lots and lots of projections. And we have some modeling groups that make projections regularly out 6 months in the future. And then they'll take some meta-analysis of some studies on mask wearing, and they'll say, well, if everybody wore masks up to this level, we would save 150,000 lives, even though from the 600,000 who will die over the next 6 months. The uncertainty in that analysis is so enormous. It is so imprecise. It doesn't tell us anything that you almost need a complicated model to tell you. I mean, we know that without seeing this. The problem is we can't get that recipe we all wanted. And trust me, we've tried in my group. I know lots of other groups that have done it as well. You know, after we published our first paper on this thing in China that I talked about, we were contacted by people at Google who were like, we took your model, because we posted the model, we recoded it, and we're trying to figure out some things about it. And we started having conversation with them, and we said, well, you know, look, what we'd really like to be able to do is to take those estimates of the reproductive number, which you can get from the dynamic model, on a daily basis and for each county. And we'd like to map onto it mobility, mask usage, policies, so that we could say at a precise level, how much gain are you getting from these individual things? And you know, you alluded to one study that we've done in New York, and it's got uncertainty on it. You know, how can you map it on so that you could actually then come back and say, all right, look, you know, Marin County, California, you right now have a reproductive number above 1, you have case growth, you only have 60% max compliance, and people are getting too close to each other. You need to get it up to 80% and close the schools for a couple weeks. That's the recipe for getting this under control. But the reality is that kind of precise diagnosis has not been attainable. Yeah, there have been lots of studies that have shown that the policies work. Now, you know, Saul Shang has one out of Berkeley. There's one out of the Imperial group that were early on that both showed that the policies have reduced the transmission of the virus. Absolutely. But is it precise enough to tell you what the individual behaviors are doing so that you could even begin to have a recipe that would say, this is what you need to do in the here and now to make this happen? So what are we stuck with? We're stuck with these sledgehammers where people are saying, you know, if you want to control the virus, do what the UK is doing right now. Shut down for 4 weeks or longer, right? Get it under control. And the thing that I find tragic is that in late April, when we were down to 18,000 cases a day, we should have done it. We should have driven it down to 500 cases a day at that point. Crush the virus to a low level, so that your test and trace capacity is sufficient to manage flare-ups from that starting point of 500 cases a day. Then you have something that allows you to reopen. Now you look around, and getting back to this experiment that we have, because you know the federal government has abdicated responsibility, and you have different policies from different states. And some of them have been disastrous, some of them earlier disastrous, some of them later. If you look at North Dakota has the highest per capita case rate in the country at this point, cumulatively, okay, for the whole time. They may be getting close to herd immunity. They're probably at 50% of the population has been infected in North Dakota, a sparsely populated big state. The best state is Vermont. Vermont had a really careful procedure in place. They crushed it down, and I know this because I had lots of conversations with them. They held it down, and in a very measured, systematic way, they reopened their economy. All right. Now, it doesn't mean it might not blow up in their face, but let's think about having a pharmaceutical intervention or two come out. Suppose in the next 6 months, we get a partially effective vaccine and a partially effective therapeutic, and between the two of them and continued mask usage, we get this thing under control so we can get to a post-pandemic period. If you were to look at that and you were to compare a place like Vietnam, which has had 1,200 cases in a population of 1 million people, If they get to the end of this in 9 months where we're post-pandemic and they can vaccinate their population and they have therapeutics to keep people from dying, that's the success story. They have 60 people who've died in Vietnam at this point from this virus. All right. If they come out of this with 200 people dead from this thing, and we come out of it, even if we stop today with 230,000 dead, they've done well and we have failed.
Right. Jeff Sachs, we want to ask a question or so. We've probably got around 15 minutes, and Giannis, and then we have some students who are posting questions that I can see, and if we have time, I'll ask you one or two from the students. So,
great.
Jeff
Well,
Sachs.
thank you. Thanks very much, Jeff, and thanks for the tremendous modeling work. I just wanted to follow up on a couple of points. One is that the Asia Pacific countries did suppress the pandemic, and they did use a suite of policies to do it. And I wonder, and the model should help us to understand piece by piece, which are important. They did not do it by the sledgehammers, as you know well. They did it by changing beta. They did it by changing the number of days of infectious people in circulation. They did it by public health targeted strategies, not by sledgehammers. Of course, we're too stupid to be able to have a discussion in this country about that. This has been clear for 6 months, but the model should really help us to piece together those specific interventions. And I just like your views on that. And to the extent to which active surveillance is really needed, and if active surveillance basically means contact tracing, or whether it means something more than contact tracing, like the carpet testing of 10 million people in a week that China has done on a few occasions. But the other countries have not needed to do that, actually. So it's quite interesting that as devilish as this virus is, it still is actually suppressible by public health means. So that was one question. Second, technically, you have a beta of about 1 and an infectious period of about 3 days, which comes to 2.4 R0. It's surprising how short the infectious period is in the model. And I just wonder whether that is an artifact of the estimates or whether you really feel people are only infectious for 3 days, within the band, because that also makes some difference. Third question is heterogeneity of spreaders, because some models have distributions on beta that seem to make a big difference and give us an 80-20 kind of distribution and change the the attack rate and so forth, and whether you've played with the heterogeneity of beta. And then the final thing is, what could we do on more detail of basically the contact dynamics? You know, one thing that's missing from these models, maybe it's in yours, but I didn't see it in the parameterization, is within household, adding in a block of what's going on in households where a lot of transmission takes place.
Yep.
So in any event, it's basically around the modeling questions and how to translate from the models to the policy. I'll just throw up one final point, which is R0 in New York right now is probably, I don't know, 1.2, 1.3. It's ugly. We've got a lot of transmission. And what is missing from our prescription right now? Probably not face masks. Is it really contact tracing? Is it quarantine? What are the key things for us to be more like the Asia Pacific rather than like Western Europe? Yeah.
All right, so lot to unpack there. I was writing them down now because I realized I wasn't going to remember them all unless I started writing down. I think I think for Asia Pacific, you're absolutely right. If we could get a hold of the data to actually have a really good analysis of it, we could see specifically perhaps how Vietnam was successful, how Taiwan was successful, how South Korea. I think generally, even without a model, you can see what they've done. And the things that made them successful was they were aggressive and they acted early. I mean, South Korea was very aggressive in spite of having that big outbreak in their fourth largest city prior to when the US really took off. Vietnam was so aggressive with this ring approach and isolation of people. It's been really impressive. And you have to have sort of this take no prisoners attitude about it, and you have to be willing to put people into isolation. And this gets to one of the things that you alluded to in one of your later questions, which is that because this virus is being spread unwittingly, because people shed it pre-symptomatically and are also asymptomatically and mild symptomatically sharing this virus, they're contagious. The power of contact tracing, the power of preemptively taking people out of circulation is enormous. Now, that's an infringement on personal liberties that people will talk about in this country quite a bit. But the reality is, for the collective good, that if you can really enforce that for people who are contacts, if you can find the contacts and isolate them, South Korea can go into your credit cards, they can go into your phone, they can go to your car GPS, they can find out where you've been so that they can actually do this effectively. They have laws on the books that they passed 5 years ago to make that happen. Here in New York City, if you go to a restaurant, my understanding is they're going to ask you to write down your name and email so that they could contact trace you if they wanted to, which is a step in the right direction. But the authority isn't there the same way. And the communication and understanding in the populace of why this is so important, why we're asking people to quarantine, is really needs to be better communicated so that they understand that they are sharing the virus unknowingly. That's so important. Again, I think we could dissect it, and why South Korea versus Taiwan versus Thailand versus Vietnam versus New Zealand, what their different strategies are, but all of them took a really aggressive tack. And these are some densely populated countries, and South Korea and Taiwan are enormously connected to the global economy. So these are not, New Zealand island nations that are often, you can say, well, this is a really different circumstance. To get to some of the, the modeling issues, we do have an estimate that's on the shorter side of about 3.5 days for the infectious period. But within our models, that's an exponential distribution. So it has a long tail, and it expects some people to be much longer than that. So we're actually comfortable with that. Now, that also gets to the issue of super spreaders. Within a stochastic model, you're going to have some people who are capable of spreading more than others, but it may not be jiggered exactly right in our model. And I'm okay with that, given the questions that we're asking. There is certainly evidence that this is a super spreader virus, that there are events where individuals will spread to many, many people. Now, whether it's because of some innate heterogeneity in how much people are spreading, or if it's just a manifestation of opportunity, somebody being at a wedding, at a choir practice, at some large gathering, at a point in time when they are actually peak shedding. That's the thing that we don't quite know, but it does seem.
It's interesting that super spreading means two very different things in the literature. One, it means a kind of meeting place, and the other, it means a heterogeneity of beta.
Yep.
Very different meanings.
Very different meanings, and it's actually very important also when you think about the structure of the network that we all exist in and how many contacts we have, because there's heterogeneity in the number of contacts that we have that give opportunities for that transmission. And a lot of what we're doing with social distancing has disrupted that network that we have. And that has what has reduced the reproductive number and the transmissibility of the virus. And how all those play out and what it would actually also mean for herd immunity are really outstanding questions that need to be addressed. Mathematically, you can show that if you have a lot more heterogeneity and critical lynch points, you need to infect fewer people to make it happen. But the problem is we don't know what that network looks like in reality. All right. So all I can say is, well, go look at Qatar. They're at 70, 80% of the population of migrant workers infected. It doesn't seem to have helped much there, So really, really challenging. I also like, Jeff, your point about households, because in some sense, you could think, well, the virus wants to get from individual to individual, but you could also think of it wanting to get from household to household. Because once it gets into a household, its ability to spread amongst those household members is really much easier than it is going between households.
Yeah.
And bringing that in is something that can be very compelling, and something that, in order to do it sensibly in a data-informed way, you have to have detailed data.
Well, one thing I did, Jeff, just a simple thing, was looking across, serological evidence across the zip codes. It's really correlated with the size of households. So
Yeah.
It's interesting.
Yeah, we saw that too, actually. We did something like that as well. And it's really, really remarkable how you can see that that is one of the stationary predictors of where you're going to see infection in New York City. Yep.
Yeah.
Yeah.
Jeff, one other quick point. Sorry to take the time, but on the question of the timing of the start of control, one thing that's gone completely haywire in our public discussion in this country is simple-minded politicians thinking that you get it under control by a lockdown, then we can go back to normal. And this is a pervasive misunderstanding that in any of our models, if you lock down, you get it down, and then you open it up, you're back to the same R0 and you're back to the same ultimate attack rate. So all you've done is stretched it out, another month or so, other than, maybe some stochastic features. So the point is, use the damn time to do something else when you open up. And I don't think that this is understood by almost any politician I talk to in this country. They think the key is to get it down to low numbers, not to change the dynamics. And that's the point.
Yeah, no, and you're absolutely right, because if you have it at a low level, if you can crush it down in the population, you have the capacity to deal with the flare-ups. You look at South Korea, which has had flare-ups.
Right.
They're getting flare-ups. They've had some issues with it. They have done this measured reopening. They opened up nightclubs. They opened up churches. They opened up lots of things. But there's such a wide use of masks, and they have such an aggressive testing and tracing process in place. They jump on it. They cluster bust. And then you can imagine that if you were to listen to the public health experts that are talking about this, the people who understand that this is effective, and say also, once you get therapeutics and vaccination, you can do ring vaccination. You can supplement it in, and you can actually target the vaccination to the places where the flare-ups are taking place.
Yeah. I really like, by the way, your language. Really changing the language in a way from contact tracing to active surveillance, because the core of this is active surveillance, that you are not just waiting for things to happen, but you are pouncing on cases, whether it's through contact tracing or any other way, actually.
So the university, Jeff, the university is doing random testing.
Yeah. I think it's a very helpful, even better way to explain the concept. Anyway, excellent work. Really great. Really great.
So we have a lot of questions. We have no time, but we have a lot of questions from our participants and from Andrew. But I wanted to turn to Giannis, who's been very patient as always. And Giannis,
I'll try to be brief.
Questions.
I'll try to be brief. So when we first were made aware of the disease, I think throughout February is when people started really thinking, at least experts, to look at the disease and try to compare it to SARS and MERS and try to understand how exactly this was going to affect us. And I remember, obviously, you and I are on a weekly basis, and we were looking at this data. For example, is it going to be seasonal? Is the climate going to have an impact? What about immunity? Are people going to be immune? And for how long? Is it SARS? We knew it was between 3 and 6 years, but this coronavirus was going to be different. At this point, there are still many things we don't know, obviously, because this disease hasn't been around for not even a year. But are there any unknown unknowns that you worry about? Like, for example, could this virus be reactivating? Once you were infected with it, is there a possibility that, just like the herpes virus, it hides somewhere in cells, and then it comes back? So that's the first question. And then the second one is about the policy. So your paper or your model showed that had New York closed a week earlier, it would have been 50% reduction in mortality, and 2 weeks would have been 90%. In terms of how realistic it was, given the context that we were in, both political and also the fact that really the US probably never has had something like that after 1918. If you had come out and started talking to a politician, even if it was a Hillary Clinton or even if it was a Biden, what was the likelihood that they would have listened and closed it down at the risk of hurting the economy? And follow-up question, are we now in a better position in the future? Because we are now becoming South Korea and Taiwan, who have been hit by SARS in 2003, that next time something comes around, we, the public health experts, will have more weight to be able to impact policymaking.
You know, I don't know for that last one. Let me see if I can come back to it. For the second one that you asked, Department of Defense was warning that this was, and intelligence were warning the president that this was a major issue in January. He in February talked to Woodward and said, I know this is going to be a real problem. There was a recognition, how much he really understands when he says that, or he's just boasting, I don't know. But there was some recognition that of how severe this is. But I also share your doubts. It's not actually even just a political issue. It's also a public compliance issue. You can tell people what to do, but are they really going to stop getting together? Are they really going to wear the masks to the degree that you ask them to early enough? And I completely agree. As I was saying, there haven't been asked for collective sacrifice since World War II for this country. We have no memory of an infectious disease like this. The last time this really impacted the US at this level was 1918, and nobody's really around from then. So that lack of memory has not served us well. We have been very buffered from infectious disease threats in this country and in many places of the world, Europe as well, for instance, such that we don't have this immediacy, this urgency that we can have to address this issue, this ability to recognize the problem, not just at the political level, but also within the public. And I think that enormously stands in the way. So when I look at that, that study we have, which is actually finally going to come out in the journal on Friday, I'm told, that it's I don't think you can point the blame in one direction. It's everywhere. I don't see public compliance to get some of those measures in place the way we would have wanted to 2 weeks earlier. That's a really, really hard ask because I just don't see people taking it seriously enough, Whether that will allow us now to take it more serious next time, I would hope so, but so much is going to depend on what it's like. I mean, imagine it's a more severe virus. Imagine it has, imagine it has twice the infection fatality rate of this one right now. Would that be enough to get people to see, look, it emerged, in some place over in, the Middle East or Mongolia or South America? This is dangerous. We can't do the mistakes we did last time. Are we going to learn again? I don't know. I mean, it's so interesting to see how South Korea put laws on the books to actually allow them to quarantine people, to test and trace, and that they had a protocol in place and they pulled it out. And how keen and ready so many of those other countries that had been in this vicinity where you get a lot of reassortment of flu viruses and where you have the emergence of, SARS was there, and obviously SARS-1 and MERS also. But I don't know. I don't know what the next 6 months are going to hold from us. I don't know what the post-pandemic period, when it will arrive, will be. And I don't know if the lessons will be learned in such a divided society where we don't even have a fact basis to work from that's common. And that's really challenging. Now, in terms of the issue of reinfection, this is something we thought quite a lot about. And it's one of the big issues, are we subject to repeated infection with this virus? And if so, what time scales? And if so, are we equally likely, less likely, or more likely to suffer severe outcomes as a consequence of a repeat infection? And the answer is we still don't know. We don't know the time scales. We've seen it has happened. And we certainly would recognize that the number that have been documented, I've seen about 24 that have been documented now at this point, isn't enough to really go by anything. It's probably a low count because of so many people may have been infected with it twice at a very mild or asymptomatic level and really not know it. Who knows? But the key questions are going to be those. I mean, are we going to start to see lots of people in 2021, if we don't have a vaccine, getting this virus a second time, you know? And then, you know, your issue about, you know, what else is there though? What could be spinning that could be problematic? Well, I think we could paint a lot of bad case, if not worst case scenarios. And we could paint some good ones also. You know, maybe people are mostly, you know, they'll not get reinfected until 10 years later. A vaccine will be just as protective and they'll need it once every 10 years. And it's 90% effective. And when you do get a reinfection, it's mild. That would be a great outcome, right? Get into the post-pandemic period and it becomes just one of these mild viruses that some people for whom they didn't get vaccinated or evades the vaccine have to deal with again. And children get it and it's very mild and there isn't too much problems with MIS-C, for instance. On the other hand, you know, you could have antibody-dependent enhancement or some sort of recrudescence after a dormancy that leads to long-term problems. This virus is not merely a respiratory virus, it's systemic in many of the infections. So what is it doing to other systems in our body? And these are issues that unfortunately time will have to tell, and we'll have to hope for the best and see what happens.
Well, that's, I think, a pretty reasonable way to end this. Jeff, this has been terrific. I was thinking just before you said that about how we're going to look back on things that really a good measure of how well we've done or how well different countries, different states, different localities have done will be the integral of cases and deaths over time as opposed to over shorter intervals. And another thought I had was, as we think about these non-pharmaceutical interventions like mask wearing and social distancing and the like, these are very public behaviors, and one of the intermediate interventions that can affect how people behave are social norms. And I think, for example, in mask wearing, you know, it's a very kind of a very public thing, and people see you with a mask or without a mask. And there's been a bit of that I've seen, just notice some patchiness in behavior, independent of the directives coming from a state government. But that's something I think that we could have cultivated much better than we have. And you don't get the kind of resistance, this kind of freedom thing, obsession that people have here in the US. That's much more of a feeling of belonging, right? And a sense of responsibility to one's community. So there's an awful lot we have to learn. It's been exciting for everyone to work on this topic or to think about it. Jeff, you've produced an enormous amount of work in a very short period of time. I'm surprised you look as rested as you do today. But on behalf of everyone, I really want to thank you. It's been great. I apologize to all the students who asked great questions. You did. I saw them. Thank you so much. But we're short of time, and I think that's just that's a tribute to Jeff Shaman and his work, that it's so interesting and so important that we can't get enough of him. So thank you so much, Jeff. Really appreciate it.
All right, everybody be well.
Bravo. Thank you.
Thank you.
Talk soon.
Take care.